Welcome to this session and thank you for joining us. My name's Sue Thoms, I'm the Commercial Director for Convatec and I'm actually hosting this session. As you can see, we've got a couple of speakers, so hopefully it'll be a nice pacey session. Our session is around advancing intermittent catheter technology, a path to better patient outcomes. And we really do hope this will share some practical tools and skills as well as showing you the latest science. So, full team that we have here. As I said, my name is Sue, and we have Laura and Sarah who are nurses. And it was originally billed as Jane, but you can see that Jane is not here. But we have Dave Pollard, who is a R&D scientist who's worked very closely with Jane and co-authored a lot of the research that we're going to show you today. In the back, I have two lovely colleagues in these lovely pink tops who, if you are interested in what we've talked about today, if you want a sample of our product, our contact details, they've got some lovely purple bags that you can collect from the guys. We had to make a decision of whether we do the symposia or whether we have a stand, and we decided to do the symposia to share our new technology. So, what are we actually going to cover? We're really focusing in on what is the issue in terms of catheters. And I think it's already been mentioned with the Urology Foundation, who we also work quite closely with, urosepsis. You know, the burden in the community, it's really important that we look at what the cause is and where and how can we minimize that risk. We're then going to talk about catheter technology. It'd be really interesting to just see in the audience, who currently works in primary care? Could you put your hand up? So, a few of you in the community. Does that mean the rest of you are all in the acute? Yeah, okay. So, where does it start in terms of those patients and how can we work together? Because it is a multidisciplinary team that needs to work together. And then we're going to talk about the science and the latest technology in terms of catheters. And finally, some practical tools in terms of audit and patient support. But without further ado, I'm going to pass over to Sarah.
Good afternoon. So what we want to talk to you today about are what are the risks of catheterization. And we know that catheterization is often necessary. A lot of our patients get them, but it's not without any risks. So we need to be really mindful of that. Patients can experience varying forms of pain and discomfort during the insertion of the catheter, throughout its use. And we know that patients often complain of bladder spasms when the catheter is in, when they're at home. But we also know that even the smallest microtraumas to that urethral lining can trigger inflammation, it triggers nerve sensitization, and it makes that whole area more reactive and sensitive over time. In more severe cases, improper technique of insertion can cause urethral tears, bleeding, and catheter use can result in scarring, so patients develop urethral strictures that narrow that urinary passage. And we also know that they can get urethral erosion around their bladder neck and also around the urethral meatus. And we also know that some patients can actually suffer some penile cleavage as well. So these are all significant issues that can occur when patients have a catheter in situ. But perhaps the most concerning for the patients is the increased risk of infection. And catheter-associated UTI, it's common and it can escalate really, really quickly, as we know, if it's not treated properly. So what we're going to look at now is the ongoing, if it moves on, yes, the ongoing burden of CAUTI. And I know it's something that you're probably all very familiar with. In the UK, urinary tract infections remain the second most common healthcare-acquired infection, and more than half of those are linked to catheter use. So that's over 52,000 CAUTI cases every year, and about 7,500 catheter-associated bloodstream infections. So the scale is really quite significant. The risk of CAUTI increases between 3 and 7% for every day that that catheter remains in place. So that duration of the catheter being in situ is a modifiable risk factor for our patients. Beyond infection itself, the wider impact is quite substantial. For patients, CAUTIs cause pain. They really affect their quality of life. They get quite anxious about them. but sometimes they really can progress to urosepsis, and Mary talked really beautifully earlier about the dangers and risks of urosepsis for our patients. From a systems perspective, we know that there are really heavy resource implications. We know that patients come back for repeat appointments. We know that they have to have their diagnostic testing. We know that they have to have antibiotics prescribed. And we also know then the impact for the nurses with having repeat catheter changes. So there's also a financial burden. So not just to the NHS, but also to the patients, because the patients generally won't go to work if they have a CAUTI. They'll want to stay at home. They're going to feel pretty miserable. We know that CAUTIs are associated with increased mortality, there are increased hospital stays, and we know that there's increased length of stay in the hospital and hospitalisation costs. So while CAUTIs can sometimes be seen as an expected risk that we potentially expect might happen, they come at a really high risk. We need to be careful, and we need to look at how we're managing them. We need to look at our infection control practices. We need to look at the patient education, but we also need to look at new alternatives, which is where we're particularly interested in increasing the use of intermittent catheters for those patients. So urosepsis, it's been talked a lot already today, but it's a sepsis that originates from a urinary tract infection. It enters the bloodstream, it triggers that systemic and potentially life-threatening response. In catheterization, in catheterized patients, that's particularly at risk for them. And we know that there are around 245,000 cases of sepsis in the UK every year, and that impact is quite sobering. Sepsis is now a leading cause of death, responsible for more fatalities than lung, bowel, and breast cancer combined. What's important for us to be aware of is that roughly 70% of those sepsis cases, they'll begin in the community, and the rest will be in hospital associated with catheter use. And of all the sepsis cases that you see in hospital, about 25% of them are going to be due to a urosepsis. So that's a major proportion, and the outcomes can be quite serious, as Mary described earlier. Mortality rates for urosepsis, they range from anything from 25% to as high as 60%, and that really does depend on how quickly the condition is detected and how well it's managed. So this really enforces the principles of ensuring appropriate catheter use. Does the patient need a catheter? Can it be removed as quickly as possible? Have we taught them how to look after their catheter? Is there an alternative? Should we be looking at teaching them to use intermittent catheters instead? Because we really do want to stop urosepsis before it even gets a chance to start. And that sort of ties in with the government AMR strategy. And that's their 20-year vision for sort of antimicrobial resistance. How are we going to contain and control it? And the vision is to have that by 2040, which doesn't seem very long away. They're looking at 4 sort of key themes. The first one being reducing the need for antimicrobials, optimizing the use, investing in innovation and supply, which we'll talk about more, and collaboration with others, both nationally and globally. So theme 1, it's sort of pretty honest. It's reducing the need for antimicrobials in the first place. So it's all about prevention. That's better infection control practices, public education, but it's also reducing the need, for example, does that patient really need to have a catheter in situ in the first place? So the idea is simple. If we don't need to use a device, then let's try not to. From an IPC perspective, it's all about reinforcing surveillance, education, and strict adherence to IPC protocols. When we're looking at investing in innovation and supply and access, it's sort of looking at developing different solutions and different technologies that will ultimately lessen our reliance on antibiotics. So in the context of catheterization, innovation's playing a crucial role in preventing CAUTIs. One area of progress is antimicrobial impregnated catheters that you'll all know about, which use coatings like silver alloys and anything to inhibit bacterial growth or biofilm formation. Hydrogel and silicone-coated catheters are out there to reduce that long-term friction and prevent trauma. But crucially for us, and hopefully for you, there's a growing interest in using intermittent catheters as a lower risk alternative to long-term indwelling catheters. This new technology, it's making the option more viable, so patients are happier to have an intermittent catheter than to have an indwelling catheter. We know that there are lots of different intermittent catheters out here, and what we want to do is tell you all about ours and our Feel Clean technology and how it is different and how it is innovative. These innovations, they align with the wider goals of the antimicrobial strategy, reducing infection at source. We need to reduce the need for antibiotics, and then that will help to contribute to long-term antimicrobial stewardship. So I'm going to pass over to Laura, and she's going to tell you all about the history of intermittent catheters and a little bit more about Feel Clean technology.
So I'm going to talk to you a little bit today about the history of catheters, urinary catheters, and also about the development of these catheters. So catheters have been around, urinary catheters have been around for an awful long time. They've been around since the ancient times. These ones in the top right-hand corner here are bronze catheters that the Romans used to use. The ancient Greeks used things like wood and precious metals. And then in the 11th century, people started understanding a little bit more about infections. And so they started utilizing different kinds of materials, and they started using silver catheters. In 1752, Benjamin Franklin created a flexible silver catheter for his brother. And then in the 19th century, Charles Goodyear of the tire fame, he used rubber to mass produce catheters. And then in the 1930s, it was Frederick Foley who introduced the catheter that we're all very, very familiar with today, with the balloon, so that we can leave those catheters in and they don't have to be taken in and out. However, post-World War II, Dr. Gutmann introduced the concept of sterile intermittent self-catheterization as an alternative to leaving catheters in, because people were realizing that these catheters being left in were causing more infections and more problems. And then in the 1970s, Dr. Jack Lapidus championed the clean intermittent catheterization technique so that patients could do it at home on their own using a clean technique rather than a sterile technique. Now, all of these catheters, they did try a lot of different ways of lubricating them, and one of the earliest ways of lubricating these catheters was by the use of olive oil, and then they started using things like gels and saps and things from plants. So in the 1950s, there was the launch of multi-use intermittent catheters. So the patients used to use these, and then they would disinfect them with whatever disinfectant that they were using at the time. And then a little bit later on, 1972, they started looking at how we could be using single-use catheters, but these were still uncoated catheters, so there still needed to be a way of lubricating them to get them in. And generally speaking, it was the hydrogels that people used. So some of the catheters came already prepared with the hydrogel on, or some of them came and you had to put your own hydrogel on top. Then in 1983, there was the launch of hydrophilic coated catheters, and I'll talk a little bit about that and how that all works in a couple of slides. And then in 2018, there was the launch of the integrated amphiphilic surfactant, which is the science behind the technology that is in the Feel Clean technology, which is the gentle cath catheters. But we do need to get the choice of catheter right, so we need to make sure that the right patient is getting the right catheter. So we need to have the right choice for the first time. So intermittent catheterization is now considered and recommended by NICE to be the gold standard for bladder drainage. And it should be used for patients to empty their bladder if the patient is unable to pass urine, or to manage incomplete bladder emptying by draining off a post-voidal residual. It is considered the gold standard because it offers a safer, more physiological, natural and less invasive alternative to long-term indwelling catheters. So unlike indwelling catheters which remain in place and provide a lovely continuous route for bacteria to enter the bladder, intermittent self-catheterization involves periodic emptying of the bladder, and it allows the urethra to recover between uses, preserving its role as a natural defense against infection. So intermittent catheterization significantly reduces the risk of catheter-associated urinary tract infections, which of course are a major concern in both hospitals and in community settings. It's better for bladder health, and it facilitates your normal function. Your bladders aren't always empty. They're not always on drainage. Your bladders are designed to fill and empty and fill and empty. And using intermittent self-catheterization continues to mimic this. It also helps to prevent things like overdistension and potential long-term bladder damage. So NICE guidelines recommend that intermittent catheterization should be used whenever it is clinically appropriate and practical, because not all patients are going to be suitable for using an intermittent catheter. However, it is the first line as recommended, and as you will be aware about the DRIP guidelines, which also promotes the use of intermittent self-catheterization over indwelling catheters. So what are the benefits and cautions about using intermittent self-catheterization? Well, we know that it reduces the infection risk by protecting that urethra. It also reduces the risk of blockages because obviously it's not there all of the time. It's literally just there for drainage. It reduces the risk of leaks, and so your patients are not wet and dripping all of the time because there's no catheter remaining in there to pull and tug and get sat on and stood on. It doesn't require a collection bag or a valve, so the patients don't have to have a leg bag or a night bag. They don't have to have a flick flow valve, so some patients walk around with their intermittent catheters, their Foley catheters in with a valve on, and then they can use that for bladder drainage. It improves their quality of life significantly. A lot of patients, when you first tell them that they're going to have to do this for the rest of their lives, don't really think that sticking a tube inside of them for the next however many years, 6 to 8 times a day, is actually a good thing. However, once they normally get over the initial kind of shock of the fact that they've got to do this for themselves, they find it makes their lives so much easier. They're able to start going on holiday, they're able to start socialising better than that, because a lot of people, once they become incontinent of urine, become totally isolated and they don't go out. They'll only go to shops where they know where the toilet is. So it can be a real issue for them. It can be mainly self-managed, but there are people who are not able to manage this on their own, so they do have the help of a partner or a carer, and they can actually support them while they're doing their intermittent catheterization. And it reduces those complications of kind of tugging and pulling and potential pressure damage for the catheters when they are remaining in. It might not actually be suitable for all patients. So some patients who maybe have problems with hand dexterity and things like that might not be able to use it. It may not be convenient when they're going to work and things like that. If the patients have got priapism, it is definitely not recommended. And any kind of suspected urethral tumour or injury, it is not recommended again. However, all catheters are not made equal. So we have these 3 generations of catheters. So our first generation of catheter is the one that we're quite familiar with, the uncoated catheter that we need to put some gel on to actually put the catheter in. Then they started to look at how we could actually lubricate these catheters easier. And so there was the advent of what we call hydrophilic coatings. So the hydrophilic coating of choice, which is on most of the intermittent catheters out there, is something called PVP, which is polyvinyl pyrrolidone. Essentially, it's a medical grade glue, and they coat the catheters with it. And when the catheters get wet with either water or with saline, it promotes that coating to become really slippery. So when the patients are putting the catheter in, it's really slippery and it's easy to get in. The main problem with those coatings is that they start to dry out. So after a minute or 2, and the catheter's in there still draining their bladders, the external side, the coating starts to dry out, and it becomes sticky and messy. So what then happens is that when patients remove the catheter, then they leave some residue within the urethra, which is a medium for bugs to sit on and grow, but it also disrupts the uroepithelial cells, and those little gaps within those cells can be a little spaces for infection to get into. So the third generation of catheters, which is the gentle cath catheters with the Feel Clean technology. So it's Feel Clean technology because it makes the patients feel clean. So this is the third generation of catheters. It is not a hydrophilic coating, but it has hydrophilic properties. So integrated amphiphilic surfactant is what the technology is actually called. Integrated because it's combined to make a whole. Amphiphilic means that the molecules have got both hydrophilic and hydrophobic properties. So those hydrophilic properties within the molecule attract water to the surface, and that is what makes the catheters become lubricated. So there is no coating on these catheters. They are lubricated just using pure water, which means that they slide in and they come out without that sticky residue, without that disruption to the uroepithelial lining, and without leaving a residue which is going to be a medium for potential infections. I'm just about to show you a short video which summarises some of the common problems that patients report when they are performing intermittent catheterisation.
Have to empty their bladder up to 6 times per day, 40% of users still report pain during catheterization with current technologies, and 31% of users report blood in their urine. But why is this? Most coated catheters have a PVP-based hydrophilic coating that swells to become lubricious when fully saturated. However, as hydration in the coating reduces, the catheter's lubricious surface transforms and becomes sticky. This stickiness has been shown to cause the coating to adhere to the urethral lining during use. Gentle Cath's Feel Clean technology is 100% PVP-free, creating its lubricious surface without the limitations of traditional PVP technology. Feel Clean technology's integrated non-stick properties consist of hydrophobic tail groups in the catheter's wall and hydrophilic head groups on its surface. As pure water flows over the catheter's surface, a fine and continuous layer of hydration is formed, making it lubricious without altering its physical properties. The performance of this next-generation technology has been independently demonstrated by Queen's University Belfast, where Feel Clean technology's surface was shown not to stick to or tear tissue, unlike other well-known PVP-coated hydrophilic catheters. Additionally, Feel Clean technology's integrated surface left no sticky residue in a series of agar tests with leading competitors. But what does this mean to users? Feel Clean technology's next-generation integrated hydrophilic surface is less likely to damage the urethra. Urethral damage can cause discomfort, pain, and subsequent UTIs. Additionally, users of Gentle Cath with Feel Clean technology have reported a smoother and more comfortable experience. In vitro studies, 39% less force was required to start removing Gentle Cath, as well as improved cleanliness and minimal mess. Overall, 90% of users rated Gentle Cath with Feel Clean technology as better than their usual catheter for comfort during use. Find out more about the comfort and relief Gentle Cath with Feel Clean technology can provide intermittent catheter users.
Okay, so just in summary, the Gentle Cath catheters with the Feel Clean technology, they protect the urethra because there's no sticking, so there's nothing for anything to stick to become infected. They're designed to reduce discomfort, bleeding and the risk of urine tract infections, and for minimal mess and residue. I'm going to hand over to my colleague Dave, who's going to talk to you a little bit more about the scientific evidence that supports these messages.
There's quite bold claims in that video, and my responsibility as a research scientist is really to stress test those claims. So I'm going to share with you some of the evidence that we've generated recently in collaboration with Queen's University Belfast. So the gold standard in the industry typically is to look at low friction. Low friction is a general claim that people use to talk about this catheterization. In the industry, the method for testing this is to lubricate the catheter and pull it through some rubber pads. You then get a friction reading. It gives a nice comparison because you'll see that an uncoated catheter is up here, whereas a hydrophilic coated catheter is down here. So you get that nice comparison. However, if you want to innovate and bring in a new technology, you need more intricate methods because, as you can see from the image on the screen, the urethra is not a rubber pad. It's a little bit more complicated than that. What's interesting about the urethra is that it's actually pretty sturdy, it's robust. It's actually designed to keep waste products out of the body. So this lining is pretty sturdy, the uroepithelium. And what we need to challenge, because we're working with catheter users, is that when you introduce a foreign body into the body 4 to 6 times daily, this can potentially get disrupted. Because typically when we talk about infection, for everybody, you're more colonised at the distal urethra, or the opening of the urethra, and then less colonised as you get closer to the bladder. And the danger here is if you're causing more trauma, you're essentially creating like nooks and crannies for the bacteria to grow. And then when you introduce a catheter in a few hours' time, you can then push them bacteria further along the channel, getting into the bladder, then they're at greater risk of infection. So we'll talk a little bit about our data. So in the mode of action video, they did talk a little bit about a tissue test and an agar test. We've actually moved on now. We've got a little bit more sophisticated test methods. So we've been working with Queen's University Belfast, which is the School of Pharmacy. They're a group of microbiologists, biomedical scientists and cell culture experts. So they've been independently verifying this work. This is the first test. We call this the biomimetic cell culture model. So what we've done, we've grown a layer of a uroepithelial layer on a silicone model. This silicone's actually got the same sort of shore hardness or stiffness as the urethra, so it's a soft silicone. We've then placed the product, we've lubricated it, placed the product on the cell culture, and then pulled it across immediately. And that's mimicking catheter insertion. So as described in the mode of action videos, the product is very wet at this point. So this is like the best case scenario. We then want to really stress test these products. So what we did, we tested it after 2 minutes. This is a typical time for intermittent catheterization. This obviously varies a lot depending on condition or how long you experience. So someone may be able to empty the bladder in less time, but then if you've got limited dexterity, potentially spinal cord or other neuropaths like MS, typically this can actually be a lot longer. It can be up to about 8 minutes. So what we were able to do on this test was actually test 3 different parameters. So we looked at damage to the cell line. We did this by measuring the number of cells still adhered to the cell monolayer. We could also look at the catheter, because as described in the mode of action video, we're talking about sticking. So what was really important here was to look for cells stuck to the catheter. You can see in the description below, one of the products had a lot of cells stuck to it. We did find an interesting little intricacy here, which I'll come to towards the end, was that one of the products actually fared worse in the first test, where we're looking at damage to the cell monolayer. However, it did pretty well on the second test, We investigate this a little bit more, and we think it was sticky. However, what happened was that the coating actually delaminated, so it left the cells back on the cell bed rather than on the catheter. So it's just slightly different intricacies, which was interesting to see between the different products. And finally, just to sound very scientific, we're looking at cell happiness, like how happy are the cells? You know, they've been bashed around by this foreign body. Are they still adhered to the cell? Maybe still adhered to the cell bed, but are they still, you know, they're still nice and round and intact? So onto the actual data. Could do with a pointer. So the grey one on the left is probably the most important one. So this is the baseline. So this is a uroepithelium that's not had a catheter touch it. As you can see, the percentage coverage is 100%, and that's what we are striving towards, essentially. And the good thing is it stayed at 100%, so that's telling us that the parameters of the test are not negatively affecting the test. Any changes to the data for the other products are down to interaction with the catheter. And what we can see with the green one, on the second one, the green one, that's an uncoated catheter. Uncoated catheters cause the most damage. And then looking at the hydrophilic catheters, just looking at 0 minutes, all of the products fare very similar. So for catheter insertion, the products are all generally very good. And that makes sense because these coatings, they take up lots of fluid, they get very slippery and cause very little damage. But things get a little bit more interesting as the adhesiveness comes into play. So you can see that the majority of the hydrophilic coated catheters, which are the 4 on the right, are causing more damage after the 2 minutes. I prefer the graph because it's a bit more objective. However, we've got some nice pictures here just to try and validate the findings. So you can see here, non-catheterized, so we've got an intact cell line. The uncoated catheter with no lubricant, so like a worst case control, has destroyed the cell line. And then if you go through all the hydrophilic catheters, including the IAS, which is a field clean technology, you can see they've all done pretty well. There's a lot of clicks on this. They've all done pretty well for the insertion. However, for the withdrawal, you can see a lot more differences. We then did this cell happiness, as I called it before. So these are the images. So we did a blinded study with 25 PhD students. They were not involved in the project. However, they were very much experts within cell culture. So we supplied hundreds of pictures to them like this and got them to score them. And what you can see from this summary is that the IAS catheter caused the least damage on withdrawal. And then this is the newest test. We're moving, so the obvious question is, so what? It's a single cell line. This is not sturdy as the urethra itself. So what we've done now, we've transitioned to ex vivo. This is a test model that we've been developing. You can see that the urethra is intact with agar at the start and the top and the bottom. The idea is to keep it stiff. However, there's a bit of flexibility in the middle, which mimics like the male urethra. We then lubricate the catheter, insert a set speed. We leave it indwelling for 2 minutes, and then we pull it back out, and we're able to get forces on insertion and withdrawal. For insertion, all of the products perform very well. However, on withdrawal, you can see 2 of the 4 products, PVP-coated products, cause significantly more force, and on average, all 4 products cause more. And there's actually some hot off-the-press data that's not included here that we're going to be publishing soon, where we're able to do histology and actually assess the damage, and it looks very promising. We're looking to publish that this summer, so watch this space. But just to round round all of this up, we also looked at delamination, so you can see the coatings are disrupted after they've been in the ex vivo model. The obvious question is, why is the hydrophilic IAS catheter not blue as well, even though it's been stained blue? It's because of the different mode of wetting that Laura was describing before. It just doesn't take up as much fluid. It essentially wets, then dries. It's a very simple surface chemistry, whereas the coatings really drink the water, they absorb it, and that's why they become brightly coloured. So you can see obvious delamination. And then when you inspect the urethras afterwards, the pig urethras, you can see the delamination of the coatings. The significance of this delamination is still something that needs investigating further. We've also got some clinical data. You can see that the genital calf glide has performed favourably against the other products in the clinical trial. So I'm going to hand you back to Sue.
I've got two key things I just want to share with you. Really, for those of you that are in the acute, there are patients who are being put on Foley catheters who don't need to. And you really need to speak, and often ED is the entry point of where patients come in. You need to be working with your urology teams and ED to really identify those patients. Those patients who have been in urology are going out into the community and they're not being seen again, and nobody takes accountability for them. We have a hypothesis that those patients haven't been seen, and we've just recently done an audit of 355 patients. 175 were on ISC. 87% of them had never had a review since they'd been discharged from their urology team, and half of them had had one or more UTIs in the last 12 months. 4 of them had recorded that they had gone into hospital. So we know those patients. So for those of you in the community, we ask you again, if you can work with community urology teams or talk to the hospital teams. We're doing audits, we're trying to build this body of evidence. If you want to find out more, our contact details are in the bag. The other thing I want to quickly tell you about is our Me Plus programme. I'm going to quickly shoot on. It's a full education programme for patients. Just teaching a patient ISC or how to use their Foley isn't enough. You need to get them to the space where they are confidently living with their catheter. With an intermittent catheter, they need education, they need support, video guides, and also their mental health well-being of accepting that they now need to catheterise. This Me Plus programme, if you go to the Convatec website, look at the Me Plus logo. We also have it in stoma. It's a full supported programme that is open access. There's a space for HCPs. You can request information, you can request samples, or you can request 2 of our lovely nurses to come and do some education in your setting. So we're willing to come out and tell you more about this. There's lots in there. I know our time is nearly done, and I just want to share with you a patient story about Ali. Ali is a healthcare professional who has MS, and she shares a little bit about her story. It's 2 minutes, because I am now over. But if we could do this before you go off to lunch. Thank you very much.
It's like, I'm not very savvy with text and things, but how many times do we write on Facebook or I might PMSL, pissing myself laughing? Well, you know what, it's not really fun when you really are pissing yourself laughing. It really isn't. And that's just how we've come to like normalise it. Mm. And it's tough, isn't it? Mm. It is tough. I was diagnosed 2 weeks before my 40th birthday, so what a present, with primary progressive multiple sclerosis. This affects me really with my mobility is the biggest issues. My legs are affected, so my pelvic area is affected, my dexterity, and sometimes like memory, I get brain fog, and the fatigue really is the worst. I have like crippling levels of fatigue with it. The catheter that I use now is the Gentle Cath Glide. I find this one is a lot better. One, because it doesn't use that lubricant on it, that sticky lubricant, and it's quite a soft one, so it is quite easy to use. Over the years I've been doing it, I've tried quite a few different ones, and the ones I prefer are this Glide. And what I've found that if they've got a sticky lubricant actually in them, when you withdraw the catheter, obviously that sticky lubricant is stuck in your bladder, so microorganisms will attract to that, so you've got quite a high risk then of getting a urinary tract infection or recurrent infections, and they're really debilitating. So you've got the double-edged sword. It's great to be able to catheterise to release the pressure in your bladder and not be weeing every 5 minutes, but you've also got to try and keep everything as clean as you possibly can, because of the risk of getting UTIs. You think it's terrifying, and it is, but once you get your head around it, it's not as bad as you build up in your mind. It's actually a lot easier to do. Yeah, it will free you up. It is actually more impairing, whereas as I say, you think at first it's quite debilitating, it's the step backward, it's making you more disabled, but actually no, it really does.
Thank you for your time.